is Caleb Banta-Green. I'm one of the presenters today for our first Focus on Meth presentation around the latest overdose trends and reasons for emergency department visits. I'll be joined in a couple minutes by my colleague, Dr. Lauren Whiteside. So a little bit around the Zoom webinar logistics. So only the panelists and hosts can share video and audio. Please enter your comments and questions in the chat and or the Q&A sections, and we will do our best to get to those today. And what we don't, we also via follow-up email, we'll do our best to respond to those. Encourage people to be respectful and curious and in their questions and thinking about the language they're using. So I would appreciate people's attention to that. Conflicts of interest statements. Neither of us have any conflicts of interest to report. This will be available to you. We are recording this, and so you will be able to see this and other information down the line. So the goals of our presentation. This is really this is part one of many. It's really an introduction to methamphetamine, and our goal is to provide today a broad background on the substance itself, reasons people use, and an overview of health impacts. And this is just a foundation upon which future presentations will build. And overall, we're really hoping that this series will create a better understanding of methamphetamine, the role it plays in people's lives, and how we can better support their health and well-being. So today we're going to cover what is methamphetamine, some of the reasons people use meth, share some Washington State data on methamphetamine, health impacts and fatalities, and talk about how and why people present in the emergency department related to the methamphetamine use. I'll share a little bit from some research we've been involved in, and Dr. Whiteside will share from her experience as an emergency medicine provider at Harborview Medical Center, and then we'll have some time for questions and discussion. So I'll hand it over to Dr. Whiteside.
Thank you, Dr. Banta-Green. I really appreciate the opportunity to speak with you. I wanted to touch base on stimulants in general and sort of set the stage as to why we're thinking about meth in this way. But this graphic here, is a good reminder to all of us that methamphetamine is a category of substance categorized as a stimulant, and all these substances, caffeine, prescription amphetamines, and methamphetamine, sort of act in a similar way within our brains and on our neurotransmitters. And on the bottom there, that bar, I sort of wanted to think about symptoms that one can get with use of stimulants, moving maybe from least severe to most severe. But when we think about these stimulants, we're really talking about things like heightened energy, caffeine, improved focus, and a lot of folks are prescribed amphetamines. Things like dextromethorphan or Ritalin, sorry, not dextromethorphan, but Ritalin or Vyvanse, things like that, to help with ADHD and improved focus, increased attention span. And then methamphetamine is the drug we're going to talk about today, mostly injected or smoked, and creates euphoria as well. So when we think about this again, just to kind of reiterate, it acts on the central nervous system, so it acts on your brain. And when it's smoked or injected, and the way that there's a meth group on this amphetamine molecule, it can go through the blood-brain barrier quite fast. And it increases neurotransmitters. And I'm not a pharmacist or a pharmacologist, but I think it's important to remember that it increases dopamine, serotonin, and norepinephrine. And each of those three molecules give us certain symptoms. So dopamine is sort of our pleasure center, causes feelings of pleasure, satisfaction, helps with motivation. Serotonin can help regulate learning, memory, happiness, can also regulate body temperature, sleep, hunger, sexual behavior. And the norepinephrine helps us with alertness, attention, arousal, and all those neurotransmitters or molecules in our body get sort of amped up when people are using methamphetamine. Important also to know is that meth or methamphetamine is a lab-made stimulant. And so I mentioned there that really similar in chemical structure, and you can see the chemical molecules there, to the prescription amphetamines. Things like Adderall, Ritalin, Vyvanse, and the therapeutic properties of stimulants are clear, and and researched. So things like increased wakefulness, increased focus, and as physicians, we take advantage of those as we're prescribing things like Adderall, Ritalin, Vyvanse, and as people in the world using stimulants. If you drink coffee or tea or any sort of caffeine, you'll probably experience that increased wakefulness and increased focus.
So I'll take over here for a little bit and talk a little bit about what are some of the long-term effects of stimulant use. And I want to point out that this diagram and a few things I'm going to share here are from a colleague in San Francisco, Dr. Phil Coffin and his group at University of California, San Francisco, a really nice provider guide around opioids and stimulants. Again, it's aimed at healthcare providers. We're actually working on some parallel materials this next year for other folks who might be part of the care team and for folks who are more doing harm reduction oriented work. So just noting that document is a really nice reference tool for people to take a look at. And just at a very high level, thinking about what are some of the health effects of long-term stimulant use. There are certainly some cognitive effects in terms of cognitive decline, increased impulsivity, stroke or cardiovascular effects, drug-induced psychoses. Those are some of the cognitive things we see. We also can see some real damage to oral health, which is really important for a lot of different reasons. People need their teeth, but it also can be a vector or a way in for a lot of infections as well. Also impacts on the respiratory system, chronic obstructive pulmonary disease. I'll try to get through all these acronyms, and other lung disease. And then a lot of effects on the heart, and we'll continue to talk about that. Enlarged heart, heart failure, arrhythmias, elevated blood pressure, atherosclerosis, sort of chronic effects, things that often that happen as many people age and get cardiovascular effects in their bodies, happen with methamphetamine more often and more quickly, generally. And then there are also impacts related to sexually transmitted infections and HIV transmission through various behaviors that people engage in. And then for folks who inject, there can be injection-related infections as well. So, and we'll talk a bit about this now. This is really important. I think it's one of the most important things to understand is why do people use stimulants? They use them for very good reasons in the context of their lives. To experience pleasure, to feel good. It can be a big mood enhancer. Those are three really potent neurotransmitters that Dr. Whiteside mentioned. And many of those can really just make a person feel good. They can enhance a person's mood. They increase alertness and vigilance and energy, and it can help people stay safe and alert particularly if they're unhoused. We hear that very oftentimes. People who are unhoused are very concerned about violence or theft at night and using stimulants to stay alert. To cope with boredom, just a thing to do that certainly can come up for some folks. Working long hours, these substances, methamphetamine is a methylated amphetamine, and these substances such as amphetamine have been used, for instance, by fighter pilots and bomber pilots for decades for these exact same reasons, for protracted vigilance and staying awake. And then also to manage pain, depression, or ADHD. And the pain piece is a bit complicated. We may talk a bit about today. Part of that might even be kind of the pain of opioid withdrawal is sometimes what people talk about, how they use methamphetamine. And it's very complicated. Pain is a whole other complicated phenomenon for sure, but I think it's important that people identify it as sometimes helping with pain. And I note all of these things because if you don't understand the reasons that people use stimulants and help them address those reasons that they use stimulants, the chance of being able to work with them and give them supports so that they might eventually reduce their stimulant use decline. They're using stimulants for a reason. And so you're trying to address those reasons, and then we may be able to get to actually addressing the stimulant use. Getting rid of the stimulant use, it may be the last thing that people are doing in sort of their trajectory of sort of recovering or reducing their use. Really importantly, this is really wonderful work that our colleague Allison Newman and a former student CRT did several years ago, about 3 years ago, some qualitative interviews they did, and you can see the link to the report, which I know Allison will also help share in the chat. These are some of the things that people said about why people are using methamphetamine and also their interest and or hesitance in reducing or stopping their use. So this aspect here, this quote person is talking about some of the physical effects. Well, because the job that I work is really high energy. I use it. I don't really feel the effects of it. I use it as a tool to help with my energy level. And, that's something that some people might say about their coffee. So again, it's sort of a degree here. And then thinking about this from another perspective, this person mentioned, it helps the pain of missing your kids. And I know it sounds harsh, but it numbs the pain. And if I didn't numb my pain, I'd be crying all the time. So the emotional component or the mood enhancement effects of methamphetamine can be very, very important for allowing a person to just get through the day. Thinking about withdrawal, so sort of the hallmark of substance use disorder, one of the components we'll talk about is physical tolerance, and that means that when you stop using, you go into withdrawal. So this person describes kind of in an important and complicated way, because it is somewhat complicated. They said, well, I tried to stop using meth, but I was also stopping opiates. And I went through a bunch of withdrawals and then meth withdrawals. They put you down, meaning the meth withdrawals. You just want to sleep for weeks and you don't even have energy to get up and try to get life back together. So you do some meth to get energy and go do it. And then you're just back at square one. I think that really illustrates at a very human level what this cycle can be like for a person to grapple with the physical dependence on methamphetamine, as well as the other things going on in their life that may sort of spur or reinforce that methamphetamine use. So switching a little bit here, sort of continuing around substance use disorder. First, I'll note at the bottom, sort of talking about what substance use disorder is. And I'm thinking about the diagnostic criteria. There's something called the DSM-5. There are 11 criteria, but they can kind of be lumped in three ways. There's biological components. People get tolerance, meaning they need to use more to get the same effect. And they have withdrawal, meaning when they stop, they're having some bad health, physical health or mental health effects. So they're going through withdrawal. There are psychological components of substance use disorder, commonly called addiction. One of the things we talk about is preoccupation, kind of a big word, but it's something that people are thinking about it all the time. It really becomes this really pressing thing in their mind all the time. And related to that is craving. Another element of sort of psychological dependence is important here is there also can be some literal rewiring in the brain around priorities in a people's lives, where things like food and love and sex get bumped down and things like drugs get moved up. And this happens at a biological level, at a chemical level. From the outside, it might look like a person sort of changing their behaviors and priorities, and that's true. But the reason for it is there's underlying neurological factors happening. And if you have these biological components, and you have these psychological components, of course, you're going to have social impacts. People really interferes with important activities, relationships with loved ones or school or work, and folks often use in dangerous situations as well, which we'll hear about a little bit in an example later. And then, so thinking about all of that, when it comes to substance use disorder, we see different patterns across different types of substances. Among the proportion of people who use a substance regularly, not all of them have substance use disorder. I think there's a common belief that if people use drugs regularly, weekly, or several days a week, that they have substance use disorder. That's not necessarily true. For cocaine, as another stimulant, people generally use it a little bit less often, and a lower proportion of them actually have substance use disorder. About 1 in 5 people who use cocaine regularly have cocaine use disorder. That's quite different than methamphetamine. Methamphetamine, about half of people who use methamphetamine have methamphetamine use disorder. We didn't put this graph here, but what I would also say is the difference between these two compounds is cocaine has a very fast effect, but a very short effect, as opposed to meth, and that can make a harder thing to sort of repeatedly use all the time, sort of hard to manage your life in that situation. Methamphetamine has a really, really long duration of effect. It can last many, many hours, even over a day potentially. And that can kind of lend itself towards, as you were hearing in its examples of how and why people use, more frequent use in terms of the number of days a week, maybe using 5 or 6 days a week. And you may really develop that substance use disorder as a result. So that's just giving a sense of what's out there, that about half of folks who are using methamphetamine regularly have use disorder. And that matters because we sometimes hear about, oh, we see a problem around a substance, we're going to mandate everybody gets treatment. Well, one, mandating treatment is not very evidence-based. That's one topic that we can talk about another day. But the other thing is that not everybody has a use disorder. That there are other things that they may benefit from, and substance use disorder treatment may not be that thing. And it is often people's reflexes, oh, you use drugs, you must have use disorder, you must need treatment. That's not necessarily the case. So interestingly, we found really similar proportions here around sort of what we identified here as the main drug of use. So let me explain what these data are. This is from the Washington State Syringe Service Program Client Survey. This is over 1,600 folks. surveyed at about 24 syringe service programs across Washington state. And what these data look at are by drugs people used in the past week, what drugs did they use, and what proportion of them identified it as their main drug. And I'll point a couple of things out here that I think are really interesting and important. So methamphetamine, 89% of respondents said they used methamphetamine in the past week. That is a large increase over the last decade. So I'll just note that first and foremost. A lot of folks are using methamphetamine. A substantial minority, about 39%, say it's their main drug. Now, main drug we don't define. It's just people identify it as their main drug. We think that's generally related to high frequency use. It's probably associated with use disorder. It's not the same thing as use disorder, but you can see kind of the similar proportion as we saw in that previous slide, where almost half of folks who are using methamphetamine identified as a main drug. If you come down here 2 lines to cocaine, it's about 20%, which is what we saw in the previous line. Conversely, fentanyl, 61% had used it in the last week. So that's a majority, but a lower proportion than for methamphetamine. And about 39% said it was their main drug. So about 2/3 of folks said it was their main drug. So I'm throwing a lot of numbers out there. The takeaways here I think are really important is most people identified using methamphetamine, and a substantial minority of them said it was their main drug. Very important to understand this is among folks getting services at syringe services programs or harm reduction programs. So it's within that group of folks. A few other things I think are important here from this survey. This top figure is showing opioid and or stimulant use in the last week. In the pink here on the left, you can see about 1/3 said they only use stimulants. On the right side, 7% said they only used opioids. Most common, people used both. But there are kind of 2 different main ways that people use both. In the lower left pie chart, you'll see among the folks who said their main drug was fentanyl, 88% also use stimulants. So the vast majority of people using opioids as their main drug say that they also use stimulants. Really a very different pattern among folks who identify their main drug as methamphetamine, where a much smaller proportion reported opioid use in the last week, about 1/4 of folks. So again, among folks who are primarily identify as a fentanyl or opioid user, the vast majority are using stimulants. Conversely, folks who say the main drug is methamphetamine, a small minority say they're using opioids. This matters in terms of like not just assuming polysubstance use means people are both using both drugs equally and are both as important in their lives. It's worth asking more. Ask another question. Tell me more about your use. What would you say is your main drug? How do you use these other drugs? How do you use them together? What are your motivations and so on? It can be really helpful for understanding what sort of harm reduction, healthcare, and or treatment services might be appropriate for that person. A little bit here, again, from the same data source on the left side. Among those folks who use methamphetamine, 57% smoked only. So a little more than half only smoked the drug. 29% smoked and injected, and 13% only injected. I actually don't know how much that has changed over time for methamphetamine. That feels about right. On the right side of this figure is fentanyl, and this is a dramatic change. Whereas 20 years ago, the vast majority of opioids being heroin were injected. We're now seeing for fentanyl, 82% only smoke. So again, kind of a takeaway from here in terms of focusing on the methamphetamine side. Most people only smoke the drug, but many people also inject and or primarily inject. So we don't want to assume sort of one route of use that people have. So now I'm going to dig into this a little bit, and I have overdoses in quotes on purpose, and there's a reason for this, and I'm going to unpack this a little bit here. So drug overdoses are technically called poisonings, and the underlying idea is that a person is taking too large of a dose, an overdose. That's what overdoses generally mean. These are deaths due to the acute or short-term impacts of a drug, not due to an injury related to the drug, not due to the chronic effects. So an overdose is the prototypical definition is used more than your body can handle, and it's due to the short-term impacts. Over the last 5 to 10 years, folks are often using this term overamping to describe stimulant overdoses in quotes. And this quote here is from folks at the Harm Reduction Coalition. The way they say it is with speed or coke, unlike some drugs like heroin, it is much more unpredictable. Overamping might happen regardless of how much or little you use or how long you've been using. So it's not just about the dose in that day. It's much harder to sort of predict, as opposed to opioids, generally often is really related to that dose. What I will note in these instances as well, which I think is important to understand, methamphetamine for a long time in Washington State and certainly the West Coast is very pure. It's 90 to 95% pure, and most of the methamphetamine that's sold as methamphetamine is methamphetamine. On the flip side, something like opioids, the potency is all over the place. It could be 2%, it could be 90%. So this idea of an overdose also makes more sense in the context of opioids, where the potency varies a lot. With methamphetamine, the potency doesn't vary nearly as much on average. So a few things here I want to say also. So for methamphetamine-involved deaths, there's often evidence that the person has consumed methamphetamine, and other causes may not be obvious. So in particular, there might be some heart or cardiovascular things that may not be detectable by a medical examiner or a coroner, even when they are significantly involved. So it's kind of in the context when I talk with medical examiners and coroners, they're like, well, as best I can tell, I think it was a methamphetamine overdose. It's not obviously something else, so I'm going to call it an overdose, even if that sometimes feels a bit imprecise or perhaps unsatisfying. So that's how this term overdose gets used. And the reason I'm saying all of this is not to be academic. It's because it matters. The language matters because it impacts how we think about preventing an overdose from methamphetamine. If you think about how to prevent an overdose on opioids, there's a lot of things on the day of opioid use that you might be able to do. But when it comes to methamphetamine, there may be fewer things you can do on that day, besides not using, to reduce the risk of that overdose occurring. And we'll be talking about that more over the next few months as we talk about some of the harm reduction approaches and conversations we should be having with folks who are using stimulants. I'm going to dig a bit into these mortality data. And just to share with you, this is Washington State data. These data are expressed as a death rate per 100,000 population. This is looking at the last 20 years. And I'm going to zoom in a moment, but I want to show you the long-term pattern is we had a fairly consistent level of overdose deaths for much of this period of time until around 2020. So this black line is all overdose deaths. The red line is opioid-involved overdose deaths, and this is really driven by unregulated or synthetic, well, fentanyl. Interestingly, back in the day, this light blue line was cocaine. We definitely were seeing more cocaine-involved death than we were seeing methamphetamine, even as we saw a lot of methamphetamine in the community. And so I'll just pause here and say that we thought about methamphetamine-involved overdose differently, or at least I did, and was taught differently almost 25 years ago, that it wasn't that common a phenomenon. That people died from cocaine overdoses, but they didn't die from methamphetamine overdoses. And whether we're calling them overdoses or not, what we've seen in this dark blue line is methamphetamine-involved overdoses have increased dramatically. Cocaine has also increased in the last few years, but something is changing around methamphetamine. We certainly think it's prevalence, but there's probably some other things underlying this, which we'll dig into just a little bit here. Just to share with you at a big picture level over the last 20 years, you can see the overdose death rate across Washington State was 1.5 per 100,000, fairly uniform across the state. It was present everywhere. I do want to state that it was everywhere. It was not just an urban phenomenon like we often saw with cocaine. It was really everywhere. And you can see an enormous increase in the overdose death rate to almost 22 per 100,000. And we're seeing it across the state and not focused just in the primary large urban areas of Seattle, Tacoma, and Everett. Digging in here a little bit more, I know there's a lot of details, so I will definitely explain the so what here. These are these same mortality data looking at the last 10 years. So overall, these are methamphetamine-involved overdose deaths by what drugs were present. The light orange line at the bottom are opioids and methamphetamine. So this is primarily fentanyl. And when you dig into these deaths, it appears that most of these deaths that involve opioids and methamphetamine often really look like an opioid death. Methamphetamine is present, it certainly contributes, but a lot of the ways people sort of present and the characteristics really look more like a fentanyl death. In the light blue line here, this is very important, we'll zoom in on this in a moment. These are deaths that involve no other major drug. This is methamphetamine deaths without, I know there's a lot of words down here, without alcohol, benzodiazepines, cocaine, barbiturates. Really, these are methamphetamine-only deaths, this light blue shading. And you can see that has increased dramatically as well over time, although perhaps leveled off in the last few years. Then the other thing I just noticed a couple of days ago, thanks to my colleague Jason Williams running these data, you'll also see this very new phenomenon here in this orange shading here that's increasing somewhat. That's opioids, cocaine, and methamphetamine, which we almost never saw before. And I cannot explain that. I don't know what that phenomenon's about. Generally, these drugs have been pretty separate in terms of who uses them. They generally are not used together. So this is something we'll hopefully be looking at over the next year or so, is to understand more about that phenomenon as well. So the takeaway here, among this long-term increase in methamphetamine-involved overdose deaths, is predominantly involves opioids and fentanyl, and that's a big driver of it. But we've also seen some increases recently in the presence of cocaine and opioids, and a continuing large proportion that are involving just methamphetamine by itself. Why might that be? So as we look at this, this is again just showing these same data. The blue line is deaths involving methamphetamine without any other drugs. The green line is meth with other drugs. These are the same data on these other slide, just focusing on blue, meth by itself, and green, methamphetamine plus other drugs. All of this is really kind of leading to this, that this is looking at the age at death by whether a person just had methamphetamine on board during an overdose or whether they had multiple substances on board. And almost 25 years ago, you can see there was not much difference. Folks who are around 40, maybe a little bit older for meth only involved deaths, but a continuing pretty similar number in green here in terms of the age of folks. They're kind of around 40, maybe early 40s, while the proportion and the number of folks who are dying who are getting older is really what we see among those who are only involving methamphetamine. The takeaway from that is that in 2023, the most recent data we have, the median age at the time of death for polysubstance deaths involving methamphetamine was 45, and it was much, much older at 56 for methamphetamine-only deaths. And we'll this come up later, but it may be that this increase in deaths is due to a group of folks who get older. You are, of course, more likely to die as you get older. So there's a part of it is just kind of this aging group, but it also may be that there are these chronic effects that we hinted at earlier that are accumulating in folks, and that's why we're seeing this increase in deaths. A couple of quick more things on this, and I'll hand it back to Dr. Whiteside. This is looking, again, from our colleague, Dr. Coffin, down in San Francisco, looking compared to opioids, what are the other health conditions that we see at the time of death? So opioids is the way they do this is a relative risk of 1. This is compared to opioids. What matters here is that cardiac conditions were much more common for those with stimulant involved, overdose deaths. As well as cerebral hemorrhages or brain bleeds. This is important. This is combining cocaine and methamphetamine, so that muddies the water a bit, but we're definitely seeing more cardiovascular or heart and brain bleed types of things happening among folks who are dying from deaths involving stimulants. A couple more things, I'll wrap this up and hand it back to Dr. Whiteside. From 2021 Syringe Service Program survey data, we asked, in the last 3 months, have you ever felt like you were losing your mind, manic, or psychotic while on methamphetamine? So 30% sort of felt like kind of these severe psychiatric symptoms. And about 1 in 5 or 19% felt like they were having a heart attack, a stroke, or a seizure while on methamphetamine. So a pretty important minority, a substantial minority of folks reporting psychiatric or physical health effects. And overall, about 1 in 8 reported going to the emergency department because of these symptoms. So a minority of folks actually went and sought healthcare when they were having these symptoms. This is a really nice paper done by Noah Frank when he was getting his master's thesis here at the University of Washington, looked a little more into these data and what things were related to a greater likelihood of going to the emergency department for these overdose symptoms. Folks were more likely to go to the emergency department for methamphetamine overdose symptoms if they'd had a non-fatal opioid overdose. So that makes sense. There's this overlap with opioids. The main drug is goofball, which is related, but a goofball is actually when heroin and methamphetamine are combined, or opioids and methamphetamine are combined. So there's that association as well. And then also this recent blood infection or sepsis is another indication potentially related to a number of things, including perhaps injection consequences of their use. So I'm going to now hand it back to Dr. Whiteside to talk a little bit more about what she sees in the emergency department.
Yeah, thank you so much, Dr. Bantagreen. That data was such a great presentation and really sort of sets the stage. And My job as an emergency medicine doc is to see whoever comes in through the front door. And so oftentimes patients aren't coming in declaring that their symptoms are related to their methamphetamine use, or it could be that to them it doesn't feel front and center related. And so I provide this Venn diagram here to think about how I think about patients that walk through the front doors of any emergency department. And I work clinically both at Harborview and the University of Washington Montlake campus. But if we think about that big yellow circle as patients that might be in the emergency department at any one time who have methamphetamine use or use disorder, there's really only a small number of them that are there just for that. So the blue circle on the left there, that's more like an oval that says other substance use disorders. I want to call attention to something that Dr. Bantagreen said, which is again, we know that patients that come in with opioid use or opioid use disorder have a high prevalence of overlap of meth use. And we did some work, some multi-site work, but what I can tell you is that at Harborview, or what I think about in Seattle, people who have opioid use disorder in our emergency department, 80% of them were co-using methamphetamine. Or cocaine, but predominantly methamphetamine. But the flip isn't true. If we're seeing patients who are using meth, it's not that the majority of them are using opioids. Then that green circle in the middle, we're also seeing patients who have acute symptoms from psychostimulant use, and that presents perhaps as anxiety, hyperactivity, substance-induced psychosis. And so what we're seeing as emergency docs can look very similar to somebody who's having a decompensated schizophrenia or psychosis or anxiety from other reasons. But we will treat that constellation of symptoms. The green circle on the bottom is sort of any acute medical presentation that can be related to acute use. So perhaps they're using methamphetamine and having some symptoms from that overamping phenomenon that Dr. Bantagreen talked about, or they're having acute symptoms related more to their chronic use, which could be symptoms related to the prolonged effects of methamphetamine exposure. And I'll talk a little bit about that later. And then I just also want to call attention that so much of our sort of mental health care comes as it presents in the emergency department. We are thinking a lot about the overlap of substance use and mental health. And we see plenty of patients that may present with a primary psychiatric complaint that really have an underlying substance use component, and we should be paying attention to that. So this is the Harborview Emergency Department, and I just kind of want to set the stage, and I'm going to come back to this picture. But for those of you that haven't ever been to Harborview, this is it. This is one side of our, what we call the medical ED, and there's some nurses, and there's a nurse sitting in the foreground. The gentleman in black is a nurse in the background. There's some techs there getting an x-ray. There's someone in a hallway bed. There's a code cart in the back, and I'm going to come back to this picture and sort of help us think through who these patients could be and what they're there for. So I wanted to kind of set the stage with a bit of a case. And, Dr. Bantagreen talked a lot about, or he mentioned that paper by Philip Coffin and how patients who are, people who are exposed to meth, using meth, have this high rate of brain bleed or cardiovascular effects. And this is sort of a typical case that we may see in the emergency department. So we may get report from paramedics as they bring in a patient of this young person, 36, sudden onset headache and left-sided paralysis. And so as an emergency doc, we're thinking about things like stroke or aneurysm in the brain. But I'm sort of also thinking like, it's 36, this is a young person. And the rest of the history you might get from paramedics is that the EMS folks were called by a roommate who noted him to be breathing, but decreased level of consciousness, not responding to voice, can't move part of his body. The vital signs you get are here, and he's, a little bit tachycardic. So his heart rate is 105, and his blood pressure is 196/98, which is elevated. And in the emergency department, I always remind myself that everyone's allowed to have a little bit of an elevated blood pressure, but that feels quite elevated for somebody who's 36 and otherwise young. So when you sort of get him through the CT scanner, go ahead, Dr. Bantagreen. This is what you see, and I don't want us to be neuroradiologists, but I think that we can all appreciate that the right side of his brain with that big white circle looks very different from the left side of this person's brain. And this is 3 different pictures of the same brain. But with that big blue arrow there in the middle panel is showing us that there's bleeding, acute bleeding in the brain. And so what we see with acute meth exposure is related to the vasospasm, and the elevated blood pressure is bleeding within the brain tissue itself. Really different than the type of bleed you can get from a ruptured aneurysm, which would look different, and different from a ischemic stroke or a stroke secondary to not enough blood flow in the brain, which won't have this appearance on CT scan, and may have different risk factors. So I give you that case. I thought it was important to just reflect a little bit also on the way that methamphetamine effects can contribute to how patients might present to the emergency department with cardiac concerns, or just even if we think about somebody who comes to the ED with chest pain, that's such a common reason that you go to the emergency department. And we see that, I mean, that is just a typical ED presentation, and there's a lot of ways to think about it. And the workup, from my perspective as emergency physician, is really the same, because what we're trying to understand is, is that person's heart having strain to it or stress to it causing heart attack? Or is there risk for that? And so at the top of the slide, just to orient you, I have a neuron, and this is kind of a cartoon or a graphic of what the brain looks like. So the big purple blob there could be thought of as our neuron and our neurosynaptic cleft. The D's are all dopamine. So remember, we're increasing dopamine. The NEs are all norepinephrine. When you use meth, you're also increasing your norepinephrine. And the 5-HT molecules there are serotonin. So what the top half of this graphic is just reminding us is that up in the brain, we're increasing all these neurotransmitters that are then floating through the body in our bloodstream and causing some direct toxicity or direct effects on the heart and the lungs, and also causing some acute on chronic effects. So go ahead, Dr. Bantagreen. I just want to comment that the acute effects of the increase of these neurotransmitters. So when someone's using methamphetamine and they come to us with chest pain or neurosymptoms proximal to their use, what we can see is vasospasm. So that's where the artery is condensing down and we're not getting enough blood flow. And that decreased blood flow to the brain can cause what we saw on the previous slide, brain bleed. Decreased blood flow to the heart can cause chest pain, or what we might think of as like angina, cardiovascular stuff. It also causes that euphoria, that feeling that we get with all those extra neurotransmitters around. Arrhythmia, or an abnormal heart rhythm. So it sort of tickles the heart in a way that can cause the heart to beat in an abnormal way that can be dangerous. Aortic dissection sounds as emergent and scary as it is, which basically causes all these increase in neurotransmitters is causing stress on the biggest vessel of your heart, which is your aorta, and it basically rips. And that is a very serious emergency that requires a very emergent surgery. And we see that often. We can see that in patients who use methamphetamine, and you can see that in patients who have risk factors for that condition related to things like elevated blood pressure. And then the last thing I have on here, we've already talked about, which should be heart attacks and strokes. The chronic effects, I think, are really important to understand, especially as people in the emergency department, or if you are treating patients who are using methamphetamine, because even if the methamphetamine use isn't proximal to what they're coming in for, there's been a whole lot of remodeling and exposure to this person's heart, lungs, vascular system that can cause accelerated chronic disease. So we like to think of hypertension as something that occurs as you get older, but you can see somebody who's very young who may develop hypertension caused by the effects of this increased neurotransmitters causing remodeling of their vessels. Pulmonary hypertension is when the blood flow to the arteries and veins in the lungs, because the pressure becomes too high. And that is, again, from direct toxicity related to chronic exposure of meth. So it's not something that you get and then can go away once the exposure goes away. It's something that once you get requires long-term treatment as a chronic disease. Same with heart failure or cardiomyopathy. And cardiomyopathy, another way to think about that is remodeling of the heart. So the heart sort of works as a big muscle. But in somebody who uses meth chronically, the heart it can experience a lot of inflammation. And then the heart remodels and gets fibrotic. And it doesn't beat as effectively or efficiently. And it sort of becomes brittle, or it can become like a big globular heart that doesn't effectively pump blood. And somebody who's young can experience these symptoms of heart failure that we would typically think about in older individuals. Go ahead, Dr. Bantagreen. So I wanted to present this this last case. Again, as an emergency doc, we sort of are pretty good at taking care of what's really front and center to us. And this is something that could happen in any emergency department, but would for sure happen at Harborview or the UW at Montlake. But young person presents to the emergency department after a bike crash, comes to the emergency department with laceration up at the eyebrow and pain to the wrist. And so really easy to say, oh, I'm just going to sew up the lac, x-ray the wrist, get this person on their way. But once you sort of think about it and look and sort of key into some things, this person is constantly looking around, responding to internal stimuli. And by that, I mean like maybe talking to themselves or seems to be responding to a conversation that really they're only having. And then he kind of pulls over your medical assistant and says that he's being followed. You notice his vital signs, and a lot of this could be explained. He's just in a bike crash, but his temperature is high. It's 100.5. It's winter. His heart rate is 145. Well, maybe that's just because he crashed his bike. Maybe not. And his blood pressure, again, is high for somebody who is young and otherwise healthy. And in general, this person's agitated, they're hard to sit still, kind of constantly looking around, sort of gives vibes where when you look at them, you sort of yourself start to feel like you're having trouble sitting still. Like that kind of appearance, to me, feels very classically for somebody who is maybe overamping, or kind of what I like to think about it from a medical perspective is kind of toxicity from some sort of psychostimulant, which in this case would be methamphetamine. So methamphetamine and psychiatric symptoms, I think the overlap of the medical and the psych can be very prevalent, and sometimes it's just patients with psych symptoms. But this, and I kind of I went from sort of most least severe to most severe, but patients can just feel kind of agitated, and oftentimes what they need from us as emergency docs is just some time in a place to be where they feel safe and they can relax. And so oftentimes a lot of redirection or acknowledgement of like, this is a safe place here, there's nobody here following you, can be really helpful. Some patients can have hallucinations and really, there's some classic hallucinations, but they sort of can see things that other people don't see. And one of the ways to kind of talk about that can be hard for patients to acknowledge, and something that I often say to people is just like, are you seeing something that you don't think I can see? Or do you ever see things that other people can't? Just to kind of acknowledge that is something that they can say yes to. And in that case, they may need some medications. And with all of that amped up neurotransmitters, we can really help just allow things to kind of cool off with a sedative type of medication like a benzodiazepine. And then there's the substance-induced psychosis that I think is really tricky for all providers, because it really the overlap of patients with schizophrenia and psychosis and substance-induced psychosis is quite large. And so patients can have both. But oftentimes patients with acute exposure to methamphetamine can come in quite psychotic. And they will need a lot of care and support from a medical team to be safe, to ensure that they don't have toxic effects from methamphetamine and some of the emergent life-threatening causes, life-threatening overamping presentations, but they also need some mental health care. And so those patients, oftentimes what we need to do is help them with medications that are aimed at both sedation and psychosis, and then keep them in a safe place where they can be safe for themselves until the acute exposure of meth has worn off, and we can have a better conversation with them to understand whether this is an organic psychosis or substance-induced. So that's kind of what we do. So this is our picture again, and Caleb, as you kind of flip through the organization. So our patient back there in room 4 could have had that brain bleed. There's a code cart there that could be a young person with intracranial hemorrhage from methamphetamine, from acute methamphetamine exposure. You know, the second person here in Bay 2 of our emergency department is getting a chest X-ray. That's a very classic workup for somebody experiencing chest pain. And that could be methamphetamine associated chest pain, or it could be sort of some of those chronic effects. And as exposure to meth is prolonged, patients can have atherosclerotic disease and increased risk for coronary artery disease. So we get a chest X-ray to get a good look at their heart in that sense. The nurse sitting in the forefront here has eyes on a hallway bed that's kind of right where in front of the screen. And what I could tell you about working there is that that's often where patients go if they are needing someone to watch them, that if they have acute psychiatric needs, maybe they're having psychosis or you know, some effects from methamphetamine that are more mental health related. And then the last patient, the shoes here in our hallway bed, could be somebody who had who presents very much like an opioid overdose. And what this person will often tell us when they kind of after their period of observation and their opioid overdose wears off is that, man, my meth must have gotten cut with some fentanyl, or I was using meth and then I just kind of fell out. And so whether they think they're using meth that is adulterated with fentanyl, or they were using a powder that they thought was meth that was fentanyl, either way, this is a person that likely won't resonate with any conversation around opioid use disorder, even though they had an opioid overdose, because they're somebody that uses methamphetamine, and a conversation around meth risk reduction strategies would be really helpful. So that is what we see in the emergency department. And I'll hand it back to you, Dr. Green.
Great, thank you. And then just in summary, and there's a lot to summarize, but as you saw earlier, methamphetamine is used for multiple reasons, including both perceived physical and psychological benefits. About half of folks who use methamphetamine regularly have use disorder, so not everybody. Deaths have increased overall, both for meth only and polydrug involved deaths. A substantial minority of people who use meth report serious psychiatric or physical symptoms. And then, as I noted earlier, people who died of a meth-only death in 2023 were an average age of 56, or 11 years older than those who were polysubstance involved at age 45. This age difference has increased over time as the number of deaths have increased, and this may be due in part to both an aging group of users and the cumulative harmful effects of methamphetamine over time. So I want to let you know this is just sort of 101, the first of many. We have some more webinars coming up looking at more about so what? What do we do about this? Both harm reduction at certain services programs and in primary care. With some colleagues talking about what's in the methamphetamine from our drug checking network. We have 8 sites around the state doing drug checking. Also in March, looking at infectious disease testing, prevention, and treatment. Then in April, we'll talk about methamphetamine use among men who have sex with men. We'll also be doing a couple of webinars yet to be scheduled, but coming up pretty soon related to our state opioid response that are more clinically oriented for folks providing clinical care. And then we're looking at kind of bringing this all together in a day-long virtual symposium in June. So we'll share more about that with folks. Let you know we have a lot on the stopoverdose.org webpage around methamphetamine overdose. Here's a very simple flyer that can be a helpful conversation starter and good information for folks. And then a bunch of online resources, and I know Allison is sharing these with you all. We've also just created this brand new webpage. Thank you everybody here for doing that. You can see in the upper right corner around Focus on Meth, sort of this whole series that we're doing over the next 6 months. So those are some of the resources we have. So with that, I'll pause and see what questions folks may have that we might be able to answer.
We have some great questions in the Q&A. David was the first person to post any questions, and there's a similar question in the chat. Um, can you talk about if there are addiction concerns with prescription amphetamines? I have seen news reports suggesting increase in the prescription of amphetamines recently combined with regular shortages of the medication. Can see parallels between this and the initial wave of overprescription of opioids, but I don't know the addiction potential of amphetamines.
I'll just respond briefly that people can become physically dependent and develop use disorder on amphetamines. They are not as potent as methamphetamines, so they may be less likely to lead to substance use disorder. The rate of onset can be very important, and so as Dr. Whiteside mentioned, that methyl group, the meth and methamphetamine, can lead to more rapid absorption, and that also is associated with perhaps more liking or a greater likelihood of addiction. But people can develop use disorder on amphetamines. There is a completely mixed research literature on whether treating or not treating ADD, ADHD with amphetamines increases or decreases risk for future substance use disorder. I think it's fair to say we don't know, but I will defer to Dr. Whiteside to see if she has more to add on that point.
I don't have anything more to add on that point. As an emergency doc, I never prescribe these medications. And yeah, as you said, there's mixed data on whether, what comes first or how they're associated. I also think it's really important to just highlight what you said, which is the potency of methamphetamine and prescription amphetamines is different. So a lot of patients who I've taken care of who ask for, prescription amphetamine to treat their meth use disorder, it doesn't give the same feeling. So
Yeah, let me follow up on that because that's a
sure.
super important and common question as well. The idea about, well, if a person's using, this unregulated illicit drug methamphetamine and this amphetamine is similar, maybe we can just give them amphetamine. And a lot of medication studies have been done, and we'll talk more about that over the next few months. And the evidence is not good. And part of that is because people really need to get the same feel from that amphetamine as the methamphetamine. And by the time you get to that high dose, you're getting the same negative bad side effects. So they generally don't work terribly well. That said, there can be instances where people really do have ADD or ADHD, and in that case, using those stimulant medications to treat the stimulant, just to treat the ADD or ADHD can be beneficial. Complicated is the short answer, and not an easy kind of. And what I should say, it's in contrast to opioid use disorder, where we do have medications that can really stave off withdrawal and can lead to sort of an even effect and help people really move into recovery well quite quickly. So we're in a very different situation in terms of the ability to use stimulant type medications to treat stimulant use disorder that generally does not work great.
And I was noticing Joe Barsana asked that question. Are there any upcoming developments such as clinical trials for medications targeting methamphetamine use disorder? And I think that's a good thing to think about. I don't know, Caleb, if you are familiar with some trials, or I know the Clinical Trials Network they were looking at buprenorphine for people with methamphetamine use disorder. And I know there's some discussion about other types of medications. And I was working with some folks that were trialing a antibody to methamphetamine to treat the toxic effects of meth. And that is very much in kind of a early stages, but it was tested in human subjects within the emergency department. And found
A couple things I would comment on, and I'm not an expert in this, but I'm pretty familiar with the literature, and I would just share that I think, with opioid use disorder, the majority of people are going to benefit from buprenorphine or methadone. Most people will benefit, well over half. And with stimulant use disorder, with the medications that are out there, whether they are stimulant medications or whether they are medications like mirtazapine or bupropion, which are more thought of as psychiatric medications, a small minority of folks will benefit from them. Now, for folks who really don't have other things that are working for the stimulant use disorder, they certainly can be a benefit, but we're just not going to expect the same scale of effect. And what I will note, one other thing is that for folks who do use stimulants and opioids together, it can be more challenging to get them started on treatment medications like buprenorphine or methadone. But what we often find is once they're stabilized for a while, many of those folks, their methamphetamine use will eventually kind of reduce and ameliorate. And we don't know the degree to which that is sort of like due to neurological or neurotransmitter changes. It's probably a lot of it having to do with changes in life circumstances. A lot of the, as they get more stabilized in terms of their opioid use, maybe they're able to address their housing or mental health or physical health issues, some of the drivers of that stimulant use, and that stimulant use can often go down. The way I would say that, another that is it's very important for people who have opioid use disorder and use methamphetamine to continue to treat their opioid use disorder even as they continue to use methamphetamine. That can be sort of behaviorally challenging, and from a scheduling wise, it can be challenging, but we know it can be very beneficial. We know people can do very well and move into recovery over time, even if they have opioid use disorder and continue to use their methamphetamine. So it's really important to keep people engaged on those opioid treatment medications in that context.
I think you answered about half of all the questions that we had in the chat with that little discussion about medications and ADHD and good coverage. I have a question on a different topic from Jennifer Wyatt. I appreciate the language clarification regarding overdose. We have used terms like fatal and non-fatal to distinguish between overdoses that do or do not result in death. Would you share the terms you prefer to refer to each? I think in the context of methamphetamine, we're not talking about overdose. What should we be talking about?
I mean, I think that the term that's generally used is overamping. In sort of the presentation that Dr. Whiteside was sharing, clinically that she's seeing in the emergency department, it doesn't mean it's important to note that how people present in the emergency department does not necessarily the same proportion or prevalence that we'd see in deaths because one of them is more severe than the other. We may be seeing different things happening in deaths or different proportions of things happening in deaths. But the types of things that Dr. Whiteside is seeing are logically going to be related and associated with what we're seeing in mortality. I don't know what you would say in terms of like something you might expect to be more different or more common in cases that are more severe and lead to death.
I always think that term overdose or overamping is helpful when a person who presents with that type of presentation sort of resonates with it or uses it, but oftentimes that may not resonate. So somebody may come in quite agitated, having a lot of chest pain, sweaty, hyperthermic, heart rate high, and they may not resonate like, hey, this looks like an overamping. They may think of it as differently. So I appreciate the question because I think the language is really important. And if you're going to be talking to a patient and using terms that they don't resonate with, then it won't work out.
Yeah, thank you. We have time, I think, for one more question, though one of the ones in here I think is important but challenging. So I'm curious about meth use and homelessness and how access to stable housing impacts use.
Yeah, that's a tough one. Certainly, there's a lot of motivations for using when folks are unhoused, but some of the motivations for using don't magically disappear when people get housing. They may still be bored, they may still be dealing with mental health issues, they may still have use disorder. So it isn't as though methamphetamine magically goes away, use goes away when folks get housing. It can help reduce their use for some folks, and in the Syringe Service Program survey, a lot of people self-identified the majority that they thought their use would go down if they got housing. But I think what we're increasingly seeing, and there are a lot of concerns in permanent supportive housing environment in particular, but how do we do more and bring more to that environment? And I think there's a desire among survey work that we've done and our recent student Saul Petersky. The residents want more services, the staff want more services, and the managers of those buildings all want more services. So I think that is a really important opportunity to recognize that housing doesn't immediately and magically fix everything, but it does mean we can find where folks are, and it addresses some of the reasons that they're using, but it really presents an opportunity to hopefully really engage folks. And I know we don't have much time, but I will note that I think the idea that supporting the health of people who use methamphetamine is a potentially multi-year process. It's not a multi-day or a multi-week process. It can be a multi-year process to sort of unpack all the reasons that people use and address the health and cognitive effects of that stimulant use. Okay, well, we covered everything. No, we didn't. We covered a lot. And I hope it was a good start to this conversation. I really Dr. Whiteside's time and contributions to the conversation, and I appreciate the great questions. We will, again, we will be posting a recording and sharing these links very, very soon. So with that, I'll just say thank you very much for your attention and interest in this topic, and we look forward to seeing you again soon. Thank you.
Thank you.